Hello, this is Dr. Ashley Parker. The intent of this video is to have a brief discussion on direct primary care, also known as DPC, to give just some of the nuts and bolts of how DPC works. And I'll compare that mainly to what I call traditional practice or traditional family practice. So especially this lecture is meant for residents at Riverside Family Practice in Newport News, but certainly it could benefit anyone who just wants to know more about how direct primary care works. So a little bit about my background. So I'm from Eastern North Carolina, is where I was born and reared. Went to college at University of North Carolina, Chapel Hill, then medical school at East Carolina University, now known as Brody School of Medicine. I went to residency at Riverside Family Practice, a part of the Virginia Commonwealth University system. Then I came back to Eastern North Carolina to Rocky Mount. Worked there for 13 years in a medium to large size family practice only business, what I call large or medium to large. So about 10 providers, give or take, 5 to 6 doctors, and the rest physician assistants. After being there for 13 years, my wife and I started our own direct primary care practice in Wilson, North Carolina. So that was a little over 3 years ago. So that's where we are now, just the two of us. So I'll break this down into segments of comparisons. So from the patient perspective, from the doctor perspective, and then some other nuances of kind of what practice looks like, how the model works on a business level, and then some other things that you have to think about because of the patient panel that you have with direct primary care. So let's first start with some differences from a patient perspective. So again, I'm going to compare this to traditional practice. And I will give this disclaimer. So obviously, I only have one traditional practice to compare it to. I know how other people practice, but I only have my experience for 13 years with the practice I was in. So disclaimer is, it was or is a very busy family practice. I had on my panel 3,500 to 4,000 patients, which is large, larger than I recommend that you have. And of that, 2,500 or so were active, meaning they'd come to see me in the last year to 18 months. So very busy with a EMR system. Would see anywhere from 26 to low 30s would be the average. So very busy practice. So that's a disclaimer. That's not what all of them look like. Also a very productive practice. We saw lots of patients. Me personally, I always produced well. So it would be, as far as production on a RVU basis, would have been in the top 5% for family practitioners in the eastern part of the nation. So that's disclaimer, my comparison when I tell you this is what DPC looks like versus what traditional practice looks like. So from a patient perspective, so let me back up a little bit. So some people may not understand exactly what DPC is or what the main differences are. So overall, the main difference for direct primary care is that compared to a traditional practice is that there's no insurance. So patients can have whatever they want. They can have regular insurance, Medicare, Medicaid. The majority of people actually have no insurance, but when they walk in the door, that doesn't work. It's directly paid from the patient to the practice. Most people do it on a monthly level. It can be done on a yearly level, but it's a set amount that's paid. There's nothing done, again, insurance-wise, and with a few exceptions, patients really can't file it on their own, especially Medicare, Medicaid. You can't pay your monthly amount and then try to file it somehow through those organizations. It's not recognized. In fact, it's illegal if you try to do that Medicare-wise. So direct payment from patient to the doctor or to the practice. Now, that also means there's a lot of advantages So you take that middleman out of the room. So again, it's directly between doctor and patient on all aspects. Okay, so that is the main difference. Some people confuse it with concierge medicine. So some of the mechanisms on the benefits and things that you get and the interactions between the patient and the doctor, they're very similar. But the main difference there's some hybrids out there of concierge and DPC, et cetera. But if you're talking about a true concierge practice, the main difference with that and DPC is they still see patients on an insurance model, meaning patients come in, if they have insurance, the visit is coded out the same and billed out the same. So the practice is still recouping money the same. The difference being is the doctor will limit his or her panel to say maybe, let's say 500 patients. Some maybe have less than that, maybe a little bit more, but somewhere in that vicinity. And in order to limit their panel that much, they'll charge those patients a yearly fee. So that can, depending on what area of the nation you live in. So if you live in Eastern North Carolina, that might be $1,500 or more, $2,500, depending on where you are, a year. If you go out to California, LA area, you might be talking about multiple $1,000s a year fee to be a patient of that concierge doctor. So again, so they still recoup money through insurance system, but they limit their panel and limit drastically the number of patients they see per day. They're able to do that because of the fee that they charge. So direct primary care, there's no insurance. The profit or the money that passes hands is completely on what that patient pays, but it's much less. So just to give you an idea, so you know kind of what ballpark we're talking about. So with my practice and with several others that I know personally, a total yearly amount for one adult coming to a DPC practice, you're talking about on the order of $600, give or take. So there's some fees that can be done different ways, but $600 to $700 would be the most for one in this area. Again, cost of living adjustments in different areas of the nation. But so for mine personally, if you came to see me 4 times and you paid up front on a yearly level, you're talking about $600 for the year, and you get all the benefits of a DPC practice that we're going to talk about. So that's the main nuts and bolts differences: direct primary care, traditional concierge. Okay, so now let's go back, like I was saying, let's compare to a traditional practice in the DPC, what it looks like from several perspectives. So from a patient perspective, so how I used to practice in that traditional office, I would see, like I said, 26 to 30 patients a day. So what does it look like for a patient? So typical day, unless you had the first couple of visits of the morning or the first couple right after lunch, you're going to wait for a while. And that's what you'll commonly hear from patients as wait times at their doctor's office. So for me personally, if you got to me, if your visit was towards the end of the morning, you might wait anywhere from 45 to 90 minutes. And that was just how it went. I try to be pretty complete in what I do, taking care of patients. So even if I were behind, I was still gonna try to give each patient their due. But I might be an hour and a half behind on a bad day. So that's wait time. Now, compared to a DPC office, the longest my patients might wait is usually 15 minutes or so, maybe 20 minutes. It's typically 5 to 10. And the wait time, they don't know this, but the only reason they're waiting then is because I'm in my office reviewing their chart, so that I'm coherent when I come in. I've already reviewed their labs, written little notes on their labs, looked at their last visit, put some, prepped my note in the EMR. So when I walk in the door, I'm ready. So it rolls. So if it weren't for doing that, then there'd be, less than 5-minute wait time all the time. So difference in wait time for the patient. Accessibility. That's a big one for DPC. What I mean by accessibility means I need to see my doctor. How much access do I have to him or her? So traditional practice, let's say especially if it were February, right in the middle of flu season, or something like that, or it can be any time. If you just need to see him for something, a sick visit. So I know for me personally, depending on the week, you may have a hard time seeing me for several days. Now, you might be able to see one of the mid levels that day, but seeing a lot of patients want to see their doctor, the one that they've seen for years. They want to see that person. So in my traditional office, on a good day, you might be able to get in to see me, but on average, you were not going to see me on a call in that day. Now, the practice we were at, we would share patients for acute visits, meaning for chronic visits, I would see my own patients. But for acute visits, it was spread out. So if we had 10 providers, whoever had an open spot, then you could see that one for an acute visit, for a call-in, a sick visit. But on a really busy day, unless it was something dire, like say in the middle of flu season, it's potential you might get pushed to the next day. Now, what does it look like in our DPC office? So the way that things are scheduled, so get this, so we schedule a grand total of one patient per hour. So that's how it starts off, and then we leave space for one work-in every hour. So that's 16 patients maximum in a day. I've never seen 16 a day. I have seen 15 a couple times. So I've been there, this is 3.5 years. So just FYI, I'm a patient panel. So this is so my wife is also a physician. It's the two of us in the office. She works part-time, always has, because we have 5 kids. So between the two of us, we have 1,100 and some patients, and I've never seen more than 15 in a day. Okay, so that space is left open each hour for a work-in visit. Now, sometimes we fill them in if I have, some different things. They're not always all 8 left open at the beginning of the day. But if somebody needs to be seen, depending on the acuity of it, so if somebody absolutely wants to be seen that day, they get seen. And that's pretty much how it is. If it's something that, say it's a really busy day, or busy day from a DPC definition, or say there's something, I have a meeting, or I'm doing something that I'm going to leave the office at 3, say something like that. So the day's gotten a little jammed. Somebody needs to be seen, I'm going to see them still. I'm going to work because I'm going to work them in somewhere I have space. If it can be put off to the next day, if it's not super urgent, then I'll just see them the next day. But bottom line is there's accessibility, and it's me. It's not somebody else. So DPC patient, you want to see your doctor, you'd say, I want to see him today. You're going to see me. And that's how most DPC offices are that I know. So accessibility is much different. I've already kind of alluded a little bit, but the next big one is face-to-face time. So I already told you how long my visits are. So there's anywhere up to an hour, and a minimum of 30 minutes. Average is 45 minutes for a chronic care slot. Now, people that come for acute visit, they don't need to be seen that long. They don't want to sit in there that long if they're just sick, right? So it doesn't take that long for a sick visit. But a chronic care visit, so the typical diabetes, hypertension, hyperlipidemia, and add on a couple other things, 30 to 45 minutes, you can roll through that pretty quickly if you're being in-depth, especially if you add in preventative medicine, which is good to do that whenever you have a chance. So the face-to-face time is dramatically different compared to traditional practice. My visits at my other office, 15 minutes. I would have a couple of slots throughout the day, maybe 2, 3. I don't think it was any more than 4, but I think it was more like 2 or 3 that were 30-minute slots. And typically those were reserved for patients that we know were exceedingly difficult. Usually it was going to do a complete physical. Say had a lady that had to do a complete physical, but she also has, say, diabetes and hypertension and so forth. So there's several things to do and take care of. So I did have a couple of 30-minute slots, but not always. So sometimes you get all that stuff crammed into 15 minutes. So that's rolling through there. So there's not as much face time and is not as much in-depth discussion of issues. So from a patient perspective, so the classic one, if you hadn't gotten this yet, just hold on, you will if you practice medicine long enough. A little old lady or little old man rolls in, and pull out that notebook sheet of paper that's got a list of things since the last time they saw you or over the last however long that they've just been waiting to come to see you so they can roll through this long list of problems or questions. So that's the ones that make your heart stop beating for a few seconds in a traditional practice when you know you're already 30, 45 minutes, an hour behind. So you would have to do something like, okay, pick the top two off that list, two most important, and we'll tackle those today in addition to whatever else I'm already doing. And you have to make another visit for the others because you just can't do it. You absolutely could not do it. Whereas direct primary care, I can honestly say that people have rolled in with that list. I've had the time to go through it. Now, usually some of those things are nebulous and they normally there's something that combined together. So it's not like you're having to go in depth on 15 issues. So you learn how to work through those things, but I've never had to tell somebody pick two or pick three or whatever. We'll take care of whatever it is and then we'll go from there. And what I've found and what you'll find is that once you sit down and kind of push through those issues that they've had and questions that they've had, those lists start going away. They start fading because you handle those issues. So if you just tackle it up front, it goes away. It also, by the way, reduces phone calls because you've handled those issues. So there's not something you're going to get called on in the middle of the night because you've handled it. So, so that's nice from a patient perspective. Other things that patients get. So this is comparison, and this is different. So every patient gets at my office gets email that comes directly to me or to my wife. They get a phone number that they can text or they can call, and it's us. It's not a call-in service. It's not a nurse. It's us. So, and what I found is that most patients understand acuity of things. If it's something that you can answer even the next day, they'll email. If there's something that you can answer, in the next hour or two, then they'll text you. If there's something they need to talk to you right then they call. And it's me on the line when they pick up. Now, it's not my personal cell phone number. It's a Google Voice number, but it connects to my phone. So for all intents and purposes, they're getting a direct access to me. So that's different. You cannot do that in a traditional practice because there's just too many and the burdens, etc. So taking call. So when we did call for our traditional practice, you may have, there might be a night that you don't get any calls, but typically it's going to be several. I've gone. So we're on. This is 4th of July weekend right now. So we took a couple of days off, and I've not had anybody call me yet. So this is the third day. I've had one patient text me and 2 email. So that's it. So 3 days, and I've had 3 contacts, and none that have called me. So that's some differences there, some little nuances for patients. They get, again, that's an accessibility thing. So accessibility in the office, accessibility out of the office. They get plenty of face time. They have very little wait time. Okay. So let's look at it from another perspective. Let's look at it from a doctor perspective, what it looks like. So I've already outlined some of those things. You kind of picked up things. But what's a typical work day? So previous office in my traditional practice, walk in at 8, start seeing patients, and I might eat lunch. I rarely went upstairs or, to a break area for lunch. Every once in a while I'd breeze through there if I had a really good day. But usually I had my lunch at my workstation, and I would just kind of eat and go. If I'm an hour and a half behind, then that by the time I get to lunch, then I eat some of my lunch. We had a little bit longer than an hour lunch at that office, so you could catch up. But yeah, usually it was kind of eating on the go and then roll right into afternoon, start again. Working through, and then you had paperwork stuff, so answering phone calls, messages back to your nurse, some physical stuff to sign. I made sure, me personally, I'm a little OCD, like I think a lot of physicians are. Kind of have to be a certain bit to be able to push through, but all my stuff was done when I walked out every day. I had clean slate to start for the next day. I couldn't stand leaving stuff. So time I walked out in the evenings on a really, really good day might be 5:45. That but the average was more like 6:30-ish. I've had them push out close to 8, and that's starting at 8 and working straight. So it could be long. So that was kind of a grind after a while. So I've already talked about time with patients. From a doctor perspective, you want to be able to take care of things. So my time for patients, like I said, 15 minutes most of the time. A few patients it was 30, and then I was running behind. So that makes you feel pushed. That makes you walk in and you get, some patients are nice and some aren't when they've been waiting and they're tapping on their watch when you walk in, like you don't know how far behind you are already. So that was pressure. The time for preventative medicine, like I said, you need to be able to take time to go back through when did she last have a mammogram, a pap smear, when did they last have a colonoscopy, et cetera, bone density, all of the different preventative medicine things. You have to have systems in place, obviously. Absolutely, when you're in a regular practice like that, you have to have good systems to make sure you're tracking those things. But time is a crusher. And that can make a big difference, obviously. So I can honestly say that I'm a much better physician purely because of the time factor I have than I was before, because it makes all the difference when you're not feeling pressured like that. So big difference on the time with patients and how far you feel, how much pressure you feel. Now, one of the exceedingly nice things, especially in today's environment, is codes mean nothing to me in a DPC office because you're not working with insurance. I could care less what the CPT code is for something. I don't have to worry about, how many review of systems did I ask? And I think I did the work for a level 5, but wait a minute, I had to ask enough review of systems. Who cares? It doesn't matter. I'm not answering. There's no insurance man in my office. I'm not answering to anybody else. It's purely between me and the patient. Understand that. So if you're trying to grasp that and understand that, remember that it's not on a fee for service. It doesn't matter what level I do. The patient has paid a flat rate, either monthly or yearly, and they just come see their doctor. That's it. It's done. So CPT codes, billing codes, all those things are because you're having to satisfy somebody else's requirement. That's what somebody else says you have to do to take care of your patient. It's not what you say you have to do, right? So it doesn't matter. So when you look at my notes in our EMR that we use Practice Fusion, which is a very nice, very malleable system. You can free text in there a lot. So a lot of times for my assessments, I just free text, and you know what? You can abbreviate. So I can just put in my assessment. It might be DM, HTN, and HLD. Hyperlipidemia, whatever, however you want to abbreviate. It doesn't matter because to me, I know what it means. And if I send that note to another physician, that physician knows what it means. So, and then I might free text some of my discussion, or a lot of it I do. Some of it's templated, but anyway. So no billing or coding, no meaningful use, meaningless use. All the other things. It does patient-centered medical home. Okay, DPC does patient-centered medical home like no other, but I just don't have to prove it to somebody else, right? I don't have to jump through their hoops and their red tape to do it. So that makes it really nice. And then, so all these things are from a doctor perspective, right? So the last and biggest to me, and what you've already kind of caught on to, is the time at home. So I walk into my office now at 8, or maybe a few minutes after, maybe a few minutes before. I'm not really worried because I'm going to catch up if I'm a couple of minutes late, if I was doing something. And I walk out. If I walk out after 5:15, it's because I'm doing something business-wise. So understand, this is our practice now, so I'm also the business person for it. But even doing that stuff, I have time during the day usually. 5:45 would be the very latest I would walk out, whereas that'd be the earliest before very latest, and that's because I might be doing some business stuff. But it's usually 5, and it's often before 5 because think about this now. So seeing patients, most offices are open 8 to 5, average office, right? So say it's 4:30. I've seen all my patients, didn't have anybody else scheduled. It's already 4:30. Nobody's called yet and said, hey, I need to be seen. Okay. Why do I need to sit there and wait for the phone to ring? Even if a patient had an emergency, they have my after hours number, email, whatever. If somebody needs to get in contact with me, they can get in contact with me 24/7, 365. They've got me if they need to. So why do I need to sit in the office waiting for the office phone to ring? I don't. So, and the ladies, that work with me, so I have two, we'll get to that in just a second. I have two nurse slash everything's office managers. They love it. When they hear my keys jingle in the back, they know when I scrape those keys off my desk, they know I'm coming and it's time to go. Putting out lights down the hall as I go. So let's get out. They love it. And so that's, thinking of things also, this is a little aside, but when you keep your staff happy, things like that, you don't have to worry about them going somewhere else. So they're loyal, they enjoy working with you. So those are important points, getting off early because you've done everything you need to do. So that's it. So I'll walk out. I'm home much earlier. So I actually have started last year, and I'll do it again this year. I actually coached the middle school basketball team at my kid's school because I'm a sports junkie, but because I have time to do it and I love doing it. So yeah, I've actually have time to coach them. So among other things. So anyway, so much nicer time at home. Like I said, married, have 5 kids. So that was one of the big reasons I was looking for something different, was feeling the crush at home. All right, so I mentioned, so next part, we talk about office structure, some things. So now we're getting some of the different things about DPC, how it works and how you make it work. So the office structure is way different. The way from it, so we have to, you also have to talk about things from a business perspective. Obviously, you have to float business-wise to be able to stay in practice. So the overhead is a big deal. So DPC offices are low overhead by design. So I already told you I have 2 employees right now. So it started off, so I started first. My wife was still working at the other practice, still in traditional, for like the first 3 months before she came to join me. So when I started off, it was me and 1 employee. So she is still my office manager, my nurse, answered the phone, check in, check out, do vitals, help me with procedures. We also draw the blood there. So she drew the blood, just her and me. That was it for a while until we started building up patients enough to where she needed help. So then we hired a second lady who does also everything just the same. So it's still just the 2 of them. And then my wife works half time. So that's it. But you can do it because the volume is less, because there's fewer patients and the way you work things. So the both of them, they do all those things I said. They answer the phones, check in, check out, draw blood, vitals, help us with procedures, stocking in the office, etc. Now, some of the other business things, my wife and I divide up. So she does the in-house accounting stuff. So she keeps up with that, submits the state and federal taxes. We have an out-of-house accountant who, because neither one of us have an accounting degree, but so we have an out-of-house accountant that she runs stuff by and who does our taxes and all that kind of stuff. But she does the month-to-month things and making sure we submit taxes. I do all the bills. So I keep up, power bill, etc., paying for supplies. I order the supplies, although I'm getting ready to turn that over to my main office manager because she can do it too. We're actually getting ready to hire, so we're growing. We're actually getting ready to hire a physician assistant, and then we're going to hire a third, and also hiring a third nurse slash whatever, however you label the people in my office, because they all do everything, interchangeable in their jobs. So there'll be 6 of us. So my main office manager, the first one that came with me, she's going to take on a little bit more responsibilities, and the other 2 will be doing some more of the back in the off regular nursing stuff. So she'll start doing my supply issue right now. They give me a list and I order all the supplies. But anyway, so between right now it's 3 of us who do, and then the external accountant that do everything to make the business run. So that's a very low overhead model. as compared to a traditional practice. Now, granted, the one where I worked, I told you about 10 providers, but the ratio, there were 50 some employees. So 5 or 6 to 1, sometimes more than that, because sometimes we didn't have 10 providers. It might be down to 6 or 7 or 8, depending on people coming and going. So at least 6, sometimes 8 to 1 ratio of employees to providers, where we're 1 to 1. So much different. And that's because all the stuff you have to do for insurance. So, entire billing department just for insurance. And then you have to see more patients when you're in the insurance system. So you have to have separate groups of people for check in, check out, phone people upstairs. So it just takes a lot to make an office run traditional model. Okay. So, well, let's talk a little bit about, we'll kind of roll that in there since we're talking about profit potential for DPC. Because again, I mean, in the real world, you have to make money, right? So the profit potential for DPC, if you run it well, if you have a practice that's flushed out with patients, you're going to make more than the top end of a traditional practice. You just are. I mean, you can do the math on things and see how it works out. You have to know the overhead end of it as well. But I can tell you, so I'm just a little over 3 years in, and I told you I was a top 5% producer in traditional model. Of course, now I was not an owner of the practice. I was an employed doctor. I never bought in for several reasons, but still, we had a bonus structure. I always maxed the bonus structure. I'm already, if you factor in the write-offs, so you understand it from a business perspective, when you own the business, there's some write-offs you get, like my vehicle, my cell phone. I have to have a cell phone because my patients can call me, so that's a business write-off. If you factor in the write-offs, if you balance those things out, I already make what I made there, and I'm on the increase because we still have space to take patients between the two of us. So if you run it well, the profit potential is there. Okay, so that's the deal. All right, sorry, I have notes that I'm looking at if you didn't know. All right, so let's talk about patient panels, what that looks like, because there's a difference, as you might imagine. So in my DPC office, about 75% of my patients have no insurance. And because they come to this model because it's cheaper than what they could do if they go through a regular model. That's because a traditional practice, we speak different languages. I mean, truly, it's speaking a different language. When you go to an office that's a traditional office, if you have no insurance, the rate that you're initially charged is based on an insurance model on what they would charge to the insurance company. Now, most offices will give you some percent discount, but usually it's not going to be and can't be less than what the reimbursement is from Medicare. So if say you went, and it depends on the level of visit too. They can't tell you until they know the level of visit, right? So if you went and it was a 99214, so a level 4 visit for an established patient. So say the typical insurance charge was $150, $175 for that visit, whatever it was. So they may give you a 30% discount, right? So you're still looking at over $100. So if it were $150 and you got a third off of that, then you're around 100, right? So that's still a lot of money for a visit. And we didn't even talk about labs. So labs are expensive. Labs are also charged at an insurance rate. If you ever gotten an EOB, an explanation of benefits, and seen what labs are charged at, it's exceedingly expensive. And I'll tell you why I know that based on how we do our labs here in just a second. I'll tell you that. So you might get charged, like for TSH, might be $30, $40, $50, $60, $80 I've seen. It varies depending on who's charging what. A metabolic panel, $20, $30 usually at least. So if you are diabetic and you've got, a CMP, a lipid panel, and A1C, then you're probably hitting close to 100. You're hitting at least 60 to 70. Then you add it onto your visit, right? So if you're So on the low end of things, if you were having to pay as a cash paying patient $170 for a visit for your diabetes, well, if you go 3 times, that's over $500. So I already told you what it costs to come see me, and that's a lowball number, $170 for a visit with labs, and that's no sick visits or anything. So the bottom line is it's expensive with no insurance to go to a traditional office. So 75% of my patients have no insurance, and they come initially because it's much cheaper, but I can tell you that they stay, and I know this because patients have gotten insurance and stayed with us. They stay because of the service. Okay. Now, I still do have a good amount of patients who have insurance. Often it's high deductible insurance. Now, high deductible insurance really plugs in well with DPC because depending on your employer, depending on what your plan looks like, some high deductible plans maybe you may have to hit $2,500, $5,000, $10,000 before your insurance pays. Some of them may pay for a yearly physical, and then you have to flush out your deductible. So say it's one of those that, okay, they'll pay for a physical, where you come get your physical, and now everything else is on you until it hits that cap. So, and then what's even worse is what I was telling you, that some offices may give you a 20, 30, 40% discount. Well, if you have high deductible insurance, you have insurance. You're not going to get that discount because they have to run it through your insurance, so you get full price. So if you were a diabetic and you're employed, but your employer had one of those high deductible insurances, so you come for your physical, and if your doctor's nice, they'll make that visit also taking care of your diabetes. And say you cut it down and you only came 3 times a year. Well, those other 2 visits, you did a level 4 visit because it's going to be at least that. So say 150, 175, and then the full price for those labs, you skyrocketing over $200, probably pushing 3. Okay, so 2 more times, so you're paying almost $600 for those visits. Okay, and you didn't get any sick care, no nothing else. So it's expensive. So the bottom line is with DPC, pricing comes in underneath that for somebody with high deductible insurance. We also have several patients who have Medicare, a bunch of patients have Medicare. If it's long math here, but if you do the math, because Medicare has a deductible with it still, my patients end up paying only, it's in the vicinity of $300, give or take, for the year, more to have me as a physician, $300 for the year, with the pluses that I already told you from a patient perspective, why you might come to a direct primary care doctor. So I have plenty that understand that, and they're willing to pay $300 more, not have to wait, get plenty of care, etc. And then there's some cases, depending, where it can come out flush or even better, depending on what problems you have, what labs you want tested. Remember, like I said, there's no billing or coding. So if I want a lab done, or if my patient wants a lab done, I don't have to have a quote reason. I don't have to have a diagnosis. I just order it because I can, because I'm not answering to an insurance person, right? So I remember from those days, like, oh, I really like to check this, and I really think it's needed. They're telling me a symptom that I think it may be, or I really like to know this, but I don't know if it'll cover. Let me go ask my head lab manager, hey, will this diagnosis cover for this lab? No, but it'll cover for this if you can kind of tweak it. And like, well, then I have to be lying to say that they had this to cover that lab. So the bottom line is sometimes it comes out as good or better with direct primary care for reasons like that. Then still talking about patient panel, I even have a few Medicaid patients, excuse me. Now Medicaid, pretty much they get free healthcare, almost free. But so those come to me strictly because the type of care that they get. They have no other reason to come because they're paying out of pocket pretty much when it'd be almost free service. They come just for the level of care. Now, most of them knew me before. So when I started backing up, I told you I was in a traditional practice in Rocky Mount. I left and I went to, when I started my practice, so I had a non-compete. I went to Wilson, North Carolina, which is just south. It's just outside my non-compete, just over 20 miles. So, You can't market directly to your patients in an old practice when you're leaving. That you can't do that, but there's social media, et cetera. Patients find you. So most of my Medicaid patients were previous patients of mine that just wanted to see me, but I do have some that weren't. So that's patient panel. Now, so that brings in a whole different ball game when you have all those patients have no insurance. So this would hold for any doctor. You have to figure out, well, how do I get services for them? Labs, x-rays, mammogram, bone density, CT, MRI, colonoscopy, meds, all those things. Well, so any doctor goes through those. It's just that a direct primary care doctor has things in place by definition, by the way we work, to be able to handle those. And as an aside, some of you may be thinking, well, what about things like referrals and things like that? And are you allowed to do this and that? Everything works exactly the same. I'm still a physician. I'm still licensed. Referrals, everything works exactly the same. Ordering things, it's just when they walk in that door, we don't take insurance. We don't take Medicare. We don't take Medicaid. Everything else works exactly the same, prescribing, et cetera, okay? Now, so we got all those uninsured patients. Let's talk about labs. How you get them labs when you just told me how expensive labs were. Labs are only that expensive because of the insurance industry. Labs don't really cost that much. So when you work directly with the lab companies, LabCorp, Quest, which goes by Solistas now, and there's several other lab companies. When you work directly with them, they will contract with you for better prices. When they know, they also don't have to go through all the red tape insurance-wise. It's cut to the chase for them, so they save money on all the billing stuff. And they know that you're paying them directly. There's no haggle. So I have an account, or my practice has an account with 3 different lab companies, and we have pricing for labs. So depending on what labs we want for that patient, we may send them to a different lab company. And then each one of them sends my practice a bill once a month. So all the blood work goes on the practice accounts, and it's billed once a month, and then I pay them directly once a month. So it's like things should be. You get a service, you pay for it. It's not like I pay this person to pay that person for service and this person. So it's very direct. Again, the whole idea with direct primary care. So labs are more on the order of this. So complete metabolic panel about $3, CBC like $2.40, $2.40. A1C is a little under 3, TSH 4 or 5, PSA about 6. I can get a vitamin D level for 10. So the large majority of patients that come in, $20 will get their blood work. So, and that's also how I won't go through this in depth right now because there are different primary care offices that do it differently. So I'll just give a real brief overview. There's some direct primary care offices that you pay a monthly fee and then that's it. So for example, there's one in Raleigh, $75 for one adult per month. But then when you come in, you come as many times as you want, and there's no other charge. Now, the way they do labs is if you get labs, they charge a reduced price for labs, a little bit less than what I just told you, maybe $2 a lab, something like that. And they may also have a small pharmacy to go along with theirs, a few dollars for some of their medicines. Whereas the way I do it and the way the guy who helped me start mine, who's also in the Raleigh area. So we charge a monthly fee and then a visit fee or a scheduling fee. So for example, one adult for me is $45 a month. And then you pay $20 when you come for a visit. So you can come as many times as you want, but the labs fall into that $20. So in any kind of service for that matter, if you get an injection, like if I inject your shoulder, the cortisone, as long as it falls, for the way I do it, as long as it falls within that $20, then you don't pay anything else. Now, if my cost goes above that 20, then I charge you whatever my cost was. I make sure I cover that. Now, from a business standpoint, really, this also gets beyond the scope of this talk, but really, if you gave away services for less than it costs you, then you can be regulated like an insurance industry. because like with insurance, there are times when the patient costs them more than they got. So you can't give away services for less than it costs you. So I cover them in, plus that's not good for business to stay afloat. So if their cost, labs, et cetera, goes over 20, I charge them whatever to cover that cost. But the majority of patients is $20 a visit. So $45 a month, $20 a visit. So that's what labs cost. That's our real cost. That's real world money. That's not fake insurance prices. Like when you go to a hospital and you see some of the stuff that you get charged, it's absolutely ridiculous. And that's all inflated because insurance, they're trying to balance out for what reimbursement they're going to get. Okay. So that's how we do labs. X-rays, mammograms, bone density. I have like 3 different places who'll do those for me on the order of this, so that for cash paying patients. So again, if you have insurance, I can order it right through insurance, and that it still works the same. For cash paying patients, I have some deals worked out, and you have to do these ahead of time if you're open a DPC office. So X-rays, anywhere from $45 to $60 for up to 3 views X-rays. That includes the reading by the radiologist. Okay, so just as an aside for me, I had to go to the ER myself. Been the first time I've been to the ER, and I don't know, since I was a kid back in the fall, and I had an X-ray done, and it was $900, and I laughed. Now, I don't carry insurance like my family does one in the ministries called Christian Health Sharing Ministries, which I'll come back to that in a minute too, because that's another aside on types of patients. So you're kind of like self-pay, and then it's a group sharing within the group of the Christian Health Sharing Company. So, but you negotiate everything as a cash paying patient. So $900, and I laughed when I was talking to people. I was like, I know what this costs because I can get my patients. This is $60, $50, and you charge me $900. So now let's talk about what I'm going to pay. So we negotiated out a price on everything, on what the doctor charged, on the hospital charge, et cetera. And you can do that, by the way. This is just an aside. When you're cash paying, what you get charged from hospitals, et cetera, that's not the final answer. No, that's not the final answer. So you can negotiate prices. Anyhow, all right. So CTs, MRIs also have a couple of places that will do those for me. So mammograms, by the way, $150 to $175. Bone density, $90. CT and MRI anywhere from, with or without contrast, or with and without, anywhere from about $450 to $800, depending on the body part and contrast. MRI being on the upper end of that, CT on the lower end. Have a place they'll do colonoscopies for $875. That's inclusive cost of the doctor doing the colonoscopy and the anesthesiologist charge. If he does a biopsy, it's $50 more. So these are things that you have to do. You have to have in place. You have to have cash prices. And I can tell you, those are great prices. That colonoscopy price might sound like a lot. You look at it, if you ever get one, insurance price, what the charge was to insurance company, $875. That's including the anesthesiologist. That's a great price. Okay. Meds. Now, this is, everybody has to do this regardless, and as a general rule of thumb, there's no reason not to start in the generic world with medicines, when blood pressure, cholesterol, whatever, because you're going to have pretty close to equal efficacy, if not equal efficacy, across the board. So with cash paying patients, you start in the generic world always. Use your $4 list. Walmart, Kmart, there's some at Harris Teeter. And where I live, Harris Teeter grocery stores have good pricing pharmacy-wise. Then from there, we go to some of the discount programs like GoodRx. There's one called WellRx that does really good prices. Blink. There's several now. These they're growing. They're multiplying these discount programs, and a lot of the pharmacies have a card already right there for cash paying patients. They say they're paying cash. You'll see them reach over there and they grab a card and run it. It's one of those discount programs. So those work great. After that, there are a few conditions, especially diabetes. When you get to insulins, there are some cheap insulins, but they're not the better ones. COPD and asthma are terrible. Albuterol is just starting to go back generic. It was, for the older physicians, know it was generic for years. When they changed their propellants to HFAs, went back to name brand, and all the other controller inhalers are name brand. So asthma, COPD, and difficult diabetics, that's expensive stuff. So when I get into that word, or if there's a little specialty type medicine somebody needs and it's expensive, then you think about getting medicines free from the manufacturer. So a lot of, I mean, any office can do this. It's just the time factor involved in it. So in a DPC office, we have more time to spend. We can do it. We can streamline it. And a lot of people don't realize that you can make as much as you can as a patient and still qualify. So some of those programs you can make up to $80,000, $90,000 as a family and still qualify for free medicine. So just in our office now as DPC, it goes something like this. So we decide patient needs this. I open the door and I say, hey, Misty, hey, Tashana, I need X medicine. They have all the little icons pulled up on the computer for all the different programs, different manufacturers. They'll pull it up, print out the forms. When we come out of the office, I'll print out the prescription. When we walk out and walk up front, they'll have them ready for me, and I'll sign off, fill out whatever my part is. Some of them require the patient to submit financial information. There's some that don't. It's stuff they can fill in. So if it's one of those, it gets sent off, faxed, or mailed, however it needs to be, right when the patient leaves. So it's just like that. Now I can tell you in my old office, that was a week or 2 week process sometimes, because it was, go see this lady up front. She'll fill out some paperwork for you, and when she'd get through her list or whatever, her pile, it'd make its way back to my desk after a few days, and then I'd sign it, it'd make its way back to her desk, and when she got worked through her list, then it would get sent out. So just a more laborious process. So that's how it looks like for meds when you're thinking about uninsured patients. Okay. Now some miscellaneous things. So there's others. So we've talked about all office medicine. So the way family medicine and a lot of outpatient medicine has moved is completely outpatient, not much inpatient stuff anymore. When I came out many years ago now, we did everything. So we did adult, pediatric, inpatient care, admissions, inpatient care, newborns, and 4 or 5 nursing homes. And that slowly whittled away to none of that almost. It still did the babies part by the time that I left. So currently, I don't do anything hospital wise. I do some nursing home stuff. So, and it's very easy as direct primary care. So I see a few patients in an Alzheimer's unit in one of the nicer nursing homes. So one of my patients who was already a patient, and I used to see his mother actually at my old practice before she left and went to this out of town nursing facility. He was in my office one day and he asked, he's like, hey, do you think you could see mom in this model? And I was like, I thought about it. I was like, well, yeah, you just have to pay for her, just like you do for yourself. He's like, that's no problem. He's like, I'll pay her monthly fee, because all the patients there are going to be Medicare, usually some Medicaid. So I said, yeah, that's no problem. Now I did miss one thing previously and talk about the things for patients on the benefits for patients. I left out an important one. So I will do after hours visits, home visits, depending on the situation. So usually it's like with a kid fell and busted his head or something, a cut or whatever. So depending on where they live and where I live, I'll either meet them at the office or I'll go to their house. I've sewed up kids on kitchen tables and beds and stuff many a time. So I have a different fee. So I told you it's a $20 visit fee for when you come to the office. So if I have to do a home visit, I charge $50, which I think is very reasonable, especially if you ever pay for going to the emergency room. Patients are more than willing to pay you $50 than go pay what it costs to get sewed at the emergency room. So I told him, I was like, okay, so I just charge it like a home visit price. So you pay her monthly, and then when I go to see her, it'd be $50. And he said, okay, that sounds good. So I go out there and see those. So as I was going out there, some other families saw me and asked who I was because there was a physician actually coming in there making rounds and taking care of patients. So I added some more that way. But the bottom line is, so they still pay their monthly fee, and then I just charge my home visit amount to go see them. So you can do nursing home medicine. You could do hospital medicine just as easily. You would just have to decide what you're going to charge for an admit, for discharge, and your daily visits. Remember, you don't have to submit any billing or coding. The hospital does all that. They have their, how much does it cost for this this ICU bed or step down bed or whatever. They have all their fees, but your fee is just for your purposes. You're not submitting that to insurance, right? It doesn't matter if they have insurance or not. So the way their insurance looks at it would be, well, their doctor care was free because they didn't come to us. So they just get the hospital bill. So you decide if you want to do $100 for an admit and discharge and $50 for your daily visits or whatever you decided. You could do hospital medicine. I personally don't know of any, but I'm sure there are because there's multiple throughout the nation now, especially if you got out in the Midwest or somewhere where things are even more rural than where I live. So it would be just that easy. Okay. So that covers the main nuts and bolts of what it looks like to be a direct primary care doctor as compared to practicing traditional medicine. Now, if you're watching this and you're not a resident at Riverside Family Medicine, which, like I said, this was intended for. If you want more information, my practice specifically, you can look at www.freedomfamilymedicine.com. There are lots of, if you look up direct primary care, there's lots of information out there for you residents. If you have questions specifically based on this, you want to know more, then you guys can email me directly, and you can ask Dr. Williams or Vernita Williams for my email, or one of the ladies in the office. They all have my email, and you guys can feel free to email me directly, and I'll respond back to you with that answer. Okay. Hope you guys have a great rest of the day, and we'd love to have you in the DPC movement.